right, we'll start again. So I'll just give a bit of an overview of what area we work in. So we obviously specialise in the use of medicines, and we really work across four main areas: inhaler technique, which involves a whole lot of things around behaviours, interventions. Then we also look at special populations, such as the old, the young, those with disability, and we've done some work looking at networks, health networks around those special populations. We also work in the area of medicine use in the upper airway. So this is essentially allergic rhinitis, which is a very pharmacy-dominated area because patients can get most of their medications through the pharmacy without a prescription. And so there we've developed models of care, treatment decision trees, and triaging in pharmacy. And we've also looked at the use of apps. We're part of a large global collaboration that's looking at apps in terms of self-management. And then we work in an area which really, I call it our main translational research area, and it's really where we fit into the bigger picture of management of respiratory disease and where medicines fit in. And so here we do work that it could be in pharmacy, it could be in general practice, it could be around interprofessional care, but it's really how medicine use in respiratory disease intersects across those different healthcare domains. And the people that are in our group, obviously groups change in size over time, but our core group is mainly made up of academic and research pharmacists, so who have a pharmacy degree, but we also have medical scientists, we also have a GP who's currently doing a PhD with us, and we've got respiratory and allergy specialists who we also work with. So for the rest of the talk, I'm really just going to focus on the particular aspect of all that I think we'd really love to find some collaborators around, and that's asthma management and medicines use. So just to put the medicines use front and centre, which essentially is where it is, I'll just turn my video on. It only seems fair that you can see me too. I didn't realise it was off. So if you look at our asthma management handbook, and if you just have a look at what it lists as the core areas for asthma management. So, okay, you'll have things like diagnosis, but then you'll have assessing asthma control. And this is always done relative to what medication the person's on. Identifying management goals, collaborating with the patient, treatment, etc. Once again, very medication and treatment oriented. Reviewing and adjusting drug treatment, once again. Providing information, skills and tools around self-management. And if you look at that, once again, inhaler use, adherence around medications, written asthma action plan, so a written plan of what a patient does when their asthma gets worse, once again, all around medicines. Managing flare-ups is all around medicines, and managing comorbidities essentially ends up also being about medication use. So even though there's this whole broad spectrum of things that are involved in asthma management, a lot of it hones into medication use. Now, when it comes to medication use, this is kind of a schema of where medication use fits in. So this is actually from the global guidelines, because I think in a way they pictorially present this in a really sort of, in a good way. Asthma patients tend to be categorised by different steps. Obviously, the higher the step is, the more severe their asthma is. And as part of that, you can see that there's a whole range of recommendations with regards to medications. And if you just have a look at, say, this mild group, you'll already see that there's essentially 3 different ways in which that mild group can be treated. And then obviously they step up with doses and the addition of medications up to the severe group. Now, this essentially has been the way in which asthma has been managed for many, many years, and it's really only over the last 2 to 5 years that there has been significant changes both in the mild end of the spectrum and in the severe end of the spectrum. The severe end of the spectrum, particularly because biological agents have become available, and so then that is now bringing asthma management in a whole different domain. The other thing that's interesting to note is that while most patients should be in the mild category based on population studies, most patients would be categorised as mild, or certainly at this end of the spectrum. What we see when we look at prescribing habits is that most patients sit around step 3. So that's what they're actually getting prescribed, even though we know that the disease, most of the people are in the mild category. Now, what else do we know about patients in the community and in primary care? Well, we know that at any one point in time, there's a very high prevalence of poor asthma control. And what that means is that when we ask patients about their symptoms, and there's a very structured criteria for this, we see that a high proportion, we can categorise them as having good, poor or partial control. And studies that have been done in Australia, so I present three studies here, one which was done in the community, one which we did in pharmacy, and then another one which we did in general practice. If you have a look at the red part of the pie, that's the proportion of patients that have partial or poor control. So these are patients whose asthma is not well controlled. And you can see that there's a high proportion. The other problem is that many patients are non-adherent to their preventer medication. So the medication that they're supposed to be taking day and night regularly, a high proportion of them is non-adherent, but they love their reliever medication, and there's high usage of reliever medication. And if we have a look at the data for preventer, this is in a more severe cohort, and you can actually see these are the good adherers, and really it's at around, this is initiation of therapy. The good adherers are taking their medication 60% of the time. And then we have those that take their medication seasonally, those that are basically up and down. So adherence is a problem. And so is high reliever use. So SABAs, short-acting beta agonists, relievers, are supposed to be taken only when patients have symptoms. And we did a study a couple of years ago which looked at patients who came into the community pharmacy and asked for a SABA. And what we found was that 70% of them were using SABA to the extent that is indicative of poor control. And the other interesting thing was that 20% of them actually reported that they'd never had a diagnosis of asthma. Now, how that, we didn't delve into that because we sort of were, this was a study of 400 patients, so we weren't looking at the why. We wanted to get a snapshot of what was happening. Then we have inhaler technique, which is basically for the different inhalers and the steps required to use it. Can a patient use their inhalers? And we know that this is over a number of different years and in different studies that a high proportion of people are not using their inhalers correctly. So this is proportion that use it correctly. Anywhere in these different studies from 5% to just under 40%. And we also know that when this is about 30% of patients have correct technique, we can train them so that they all have correct technique. But when they come back after a month or 2 months, about half of them drop off again. And finally, we know that all of this is significantly complicated by the fact that patients' beliefs about their asthma and their level of asthma control can often be a bit skewed. So this is a study that we published a couple of years ago, which actually looked at, so the pie shows the proportion of patients who have well-controlled, partially controlled and poorly controlled asthma. And then the boxes outside show how many of these patients perceived their asthma was well controlled. So that in the good control group, 91% thought they were well controlled. But in the partially controlled group, 82% thought that they were well controlled. And out of those that had poor control, 50% thought that they were well controlled. So this condition, which is highly dependent on patient reporting their symptoms, whether they're having troubles, we have a bit of a disconnect here because we can't even be sure that when a patient says they're well, that they actually might be. And this is also, this perception data is consistent with overseas research. This is a European study where 40% of patients had poorly controlled asthma based on global guidelines, but they actually reported that they were well controlled. So if you can think of it from a pharmacy perspective, because the work that I'm talking about today is in particular around pharmacy, you have a patient that might come in and we want to know whether their asthma is well controlled. And we know, so if we look at this part of the flowchart, we know that if they're poorly controlled, they have symptoms, there's something going on. there's a whole range of reasons why they might be poorly controlled, some of which I've already mentioned. And so essentially the scenario might be something like this. They come into the pharmacy and probably anywhere between 50 and 80% of them at that point in time have got poor control. Perhaps up to 20% of them may not have the right diagnosis. Let's say approximately 60% of them will have poor adherence. 70% probably will have poor inhaler technique. Now, I didn't talk about rhinitis, but about 80% of them will have moderate to severe allergic rhinitis, which is poorly managed. Probably about 20% of them are smokers. We don't know about whether they're actually on incorrect therapy, and we're not sure about the phenotyping, etc. But essentially, almost every patient that will come into the pharmacy will have a number of issues that need to be identified and then solved. Now, you might say, what do pharmacists do? And some of them seem to not do very much, and some of them seem to do a lot. And how do they get it right? And how do they know what to attack first? Well, we're currently just planning a study where we're actually going to map the landscape of what pharmacists are actually doing, and we're planning a national study which will hopefully get done by the end of the year, but there's lots of things to take into consideration about that. We do have one study that was done a few years ago, which used simulated patients where, and I think one of the co-authors here is actually listening today. I think I saw Carl's here today, where a patient was sent in, and they were sent in obviously as a simulated patient. They played the role of a patient that hadn't been to their pharmacy. Now, what's interesting is that, you know, the most commonly asked question was, is this product for you? And if you look at the other things that you could say are more asthma in particular related, we're looking at less than 50% of pharmacists are asking those questions. And when it comes to inhaler technique, I mean, it's very, very low. And if you think about a pharmacy scenario where a patient comes in and out, how many questions do you think a pharmacist has in them with that patient? Probably not that many. And they're probably not going to get the answer to what they need to with the question, is this product for you? Or even, are you using a preventer? Because they could say yes 5 months ago, or yes yesterday, or yes every day. So we have some challenges. And then we have the issue of prescribing. So I always say one thing's guaranteed: a doctor's going to prescribe something and a pharmacist is going to have to dispense. And anything else outside of that, one never knows what they're going to get. But from the prescriber's perspective, there are a lot of options. And this is just really looking at the different classes of drugs. But if we actually put the different classes of drugs, plus the different inhalers, plus the different doses, there are over 250 prescribing combinations that a GP, let's talk about GPs at this, because that's sort of what's of most relevance right now, has an option with. And if a patient comes in when they're unwell only, they haven't been taking their medication, the natural thing would be the doctor asks the questions and they will actually up the dose because they think that the medication the patient's on is probably not working for them. But as we know, there's a lot of other things that could be going on. So why do we need to get it right in the pharmacy? Well, the reason we need to get it right is because pharmacists see patients up to 12 times more 12 times more often than patients might see a GP over a 12-month period. The other big thing is that reliever medications, SABAs, which basically all patients take, are available over the counter in the pharmacy. So the patient will be coming into the pharmacy for those things at the very least. The other thing is that the pharmacist is the one that actually probably has the best information about whether that patient's actually being adherent, because while the doctor might prescribe it, they actually have to get that medication dispensed. And pharmacists they don't record a lot of things in pharmacy, but they do record dispensing history and purchases. So there's literally millions of data points longitudinally for patients around their medication dispensing. So you probably guess where I'm going here. And then pharmacists actually do see quite a lot of these comorbidities, which essentially can be treated with medications without a prescription. So allergic rhinitis, gastroesophageal reflux, etc. And the fundamental thing around all this is that asthma management is very heavily medication driven across the spectrum of the disease. And then finally, patients are really selective in what they tell who, and very often they won't tell their GP something, but because of what they need or a relationship with the pharmacist, they may actually tell the pharmacist. And I think really at this point in time, the area that pharmacists really have a very important role to play is in that mild asthma category, because the guidelines are just beginning to change there, and then in the severe end of the category, because there's a lot of evidence that these patients who are at the severe end of the spectrum often take a really long time to get diagnosed. And we're doing some additional work in the severe asthma category to actually have a look at what patients' journey is. Often they take years before they get referred to a specialist for severe asthma. So where do we think that the gaps are for pharmacists, and why, what we need to get better in future? Well, the guidelines don't really address real world issues and provide real life strategies, and in particular they don't really provide any specialised clinical frameworks for community pharmacists. And it's not feasible or reasonable or practical to implement the same set of questions or approach in the different healthcare settings. I think we're pretty convinced now from years of this that it doesn't really work. And so consequently, pharmacists really do lack the tools that are going to really be able to let them differentiate and identify the problems. And I think another major issue is that up until now, if you look at anything that's been done in pharmacy, there really has been an underutilisation of these really massive data sets that pharmacy already has, and technology. So the dispensing record, but also very, very importantly, the over-the-counter medication sales and putting them together, and in developing skills. And also there's minimal focus on risk prediction. So all of it is about acute management versus risk prediction. And this is really where I think there's a massive opportunity to do something that's really, really important and really can change things. So just for the next sort of 5 to 10 minutes, I'd like to tell you about two projects that we'd love to collaborate on. And they're very different. One is building an algorithm, and the other one is, I think, really more about machine learning, but I'll just go and show you where we're thinking with these. So the first one is really to use dispensing records.
There might be a couple of questions.
Oh, yes.
Before you jump into that section, so Corinne had 2 questions for you.
Yeah.
Corinne, do you want to ask them out loud, or do you want to have a look at the chat? I can read them out if you want. So the first one was, how do pharmacists know that the patient's been adherent? And the second one is, how is pulmonary function followed in Australia for patients with asthma, and how is asthma diagnosed in Australia? Oh, those are big questions.
How pharmacists, I can touch on both. How a pharmacist monitors adherence, they will see when a patient's had their medications dispensed, and that is a crude way of seeing the timing of dispensing of those medications, because we know if patients are adherent, how often they should be collecting a new medication. It's difficult because sometimes patients don't go to the same pharmacy. However, we have an organisation who collects data back end, and I think we can get around that. So there's that. And there are validated tools that ask about risk of non-adherence, but it's very unlikely that pharmacists would actually would probably be using them. And lung function is probably not done as routinely in primary care as probably could be. Lung function can be used to diagnose asthma, but asthma is mostly diagnosed based on a patient's history, based on the triggers for asthma, based on response to medication, and then on top of that, lung function testing. But it's not routinely done in primary care.
Yeah, thank you. Thank you.
Any other questions at this stage? No, we'll continue on.
One more question.
Yeah.
Cynthia, I'm just wondering about sort of tracking about adherence for inhaler use. Do the patients return their anti-inhalers to the pharmacist?
No, they don't.
Okay. Thank you.
This is why we haven't managed to master adherence. Yeah. There are some technologies that can be, that I'll show you, I'll mention when we get to part 2, which sort of are trying to address adherence, but there's some major issues with some of those things. Okay, so let's look at the developing an algorithm for pharmacists. So we know we have the dispensing records, which will be accurate for that patient, because they're all electronically entered and we know exactly what data is there. And earlier this year, we published a paper with some UK collaborators where it was UK data, and we actually didn't have dispensing records, we had prescribing records. But what we did was we looked at prescribing clusters or behaviours of clusters. Well, we clustered prescribing behaviour so that we could see how often a patient had been prescribed an inhaler. So we know that there are patterns in prescribing, and we think that there's patterns also in dispensing. So let's have a look at this first one. So what do we have? What's the data that we have in pharmacy? Oops. So what we have is historic data, which is dispensing data from whenever that patient is basically on that record. And, you know, for some patients, it will be 20, 30 years. What we have in real time is, just say we were following this for 12 months, we would of course have the current dispensing record, but we'd also have a record of what they buy over the counter. So for the first time, really, we'd be able to look at dispensing, so prescribed asthma medicines, and over the counter asthma medicines, as well as any other medication, whether that be for their allergic rhinitis, for their gastroesophageal reflux, whether it be vitamins, whether it be herbs, whatever else. We're also working with a group in general practice who collects data from electronic medical records. And so we would be able to link up the prescribers, the prescribing and the dispensing to see lag time, etc., etc. What we also have the opportunity to do is to measure adherence in real time. And there's a group in Israel that we've been talking to who has invented a sticker that can be put on any inhaler, and it does a timestamp. Now, we're just working with them to do some validation studies in Australia about this, but this is very cool. It's a sticker that you basically put on any inhaler, and it gives you a timestamp. And then through a series of questions, which would be patient-reported outcomes, we can get clinical status of that individual, which will be all about their symptoms, and if there's any lung function measurements, etc., we could also get that, but we could get that from the medical records. And we also would look to get biological phenotyping, because one of the things that has been coming through in the evolution of our understanding of asthma is that there's different biological phenotypes which can be identified through routine blood tests. And so through a routine blood test, which most patients would have at least at some point, we could get the biological phenotyping, and then we could get behavioural phenotyping, and that comes from patient-reported outcomes. And there's recently been some work done in asthma patients' behavioural characteristics, which we could also put into that. So our idea is that we would use all this data to build an asthma risk prediction tool, which would help pharmacists to in real time identify where they need to put their energies, where they need to refer, and when, and basically help get through this, I guess, you know, multi-dimensional, multifactorial challenges with asthma management. And once we have an algorithm, a prediction tool, we want to actually validate it by putting it in practice and actually seeing, does it help pharmacists identify those high-risk patients or those mild patients? Can they identify whether they need a behavioural intervention or they need a referral, etc.? So that's really the first concept, so that when a patient comes into the pharmacy and a pharmacist can really only answer 2 questions, they're not kind of thinking about all of this. That's not what actually it happens, but it's a really sort of systematic, evidence data driven, sort of logical process. So that's the first one. I don't know whether anyone wants to comment on that at this point.
I have a question, Adam. Hi, Cynthia. I just wondered how you saw this working in practice. So with the pharmacist, a patient coming in, and then the pharmacist would find a computer and then would look the patient up, and then the tool would be working in the background and present something to the pharmacist, or how do you see it actually playing out in the practical sense?
Yeah, that's what would happen. And what happens now is that when a patient comes in, if they have a prescription, essentially they go to their computer and they scan that, and it automatically brings up the patient. And yeah, that the tool would be working behind that, and that you know, that entry of that next prescription will be the trigger for activating the algorithm. And so I think there's a lot. I think a lot of the important work is really looking at that, at the dispensing record and where the clusters exist in that dispensing record, because I suspect it won't only be in the clusters that exist in the dispensing record, it will be a key 1 or 2 questions that will have to go with that. But maybe the cluster of the dispensing record will trigger different questions depending on the pattern or the cluster of dispensing in the past. So that's how I envisage that it would work.
And do pharmacists have any other kind of decision support tools that they're using at the moment in practice in that kind of way?
They can, but none of them are linked to something like this. So what they do have is kind of independent. For example, the Pharmacy Guild might have developed with some third party an adherence screen. So what the pharmacist will get is they'll get the adherence screen is there, and the pharmacist will be reminded, ask the patient about X, Y, and Z. So they're very generic. They're generic things. They don't work. They just, I mean, because every time I think about this, you know, we obsess about asthma and respiratory all the time. It's all we think about. We do nothing else. And if we were placed in the pharmacy to see the patient, we would draw on all that 24-hour a day thinking about asthma to do this. Pharmacists have to do that for all the conditions that come up, that come through their door. So they really do need something that's going to help them in this.
Great, thanks, Cynthia.
And we have one question from Andrew Black. Do you want to say it out loud, Andrew, or do you want me to say it? Oh, we've got multiple questions now.
Oh, sure. Andrew. No, I was just wondering about Bayesian models for that.
I don't know anything about any models. That's why I'm here, so that you guys can jump in and help us do that bit of it.
It certainly could be one of the options, that's for sure. And one more question, I think it was from Carl. So Carl asks, I don't know if Carl wants to jump in, but
yeah, I can ask this one. I guess the question is more about the human factors, and as we know, the typical dispensing process is about 3 minutes or so or less. on average. And the challenge we always have is how do we embed these sort of interventions, which we know theoretically and even in trials are beneficial to patients? How do we embed that in these workflows?
Yeah, well, I think, I mean, that's always an important, you know, that's obviously a critical part of it in the end. I guess we're bracing it on the premise that by having evidence and data-driven processes that support the pharmacist, what it will mean is that the pharmacist only will need to ask 1 or 2 questions. Now, I'm just saying that because I think that is how we would be able to develop something that really is a big advance. It's just what those, you know, 1, 2 or 3 questions are is what's really critical. In terms of embedding it in, I mean, I think if it's something that's partly embedded into the software, I think that's a big thing. And if we're looking at something that's only going to be, you know, 1, 2 or 3 questions, well, that can be done that can be done quickly as well. And this is really to, once again, identify those things that haven't been identified before, because there's just too many things to potentially be a problem. And our intention is to have something that is for a pharmacist that isn't going to sit down and have a consultation with someone for half an hour. They're not going to do a disease state management process. They're not going to do a major intervention.
And we've got 2 more quick questions, but I'm worried we're going to run out of time for the rest of it. So, but very, very quickly, if you've got a quick answer, the very difficult question: are the data sets linked, from Zoe? And then one from Anthony is the end goal of the machine learning algorithm to develop 1 or 2 questions?
So are the data sets linked? Was that the first question?
Yeah.
So we can get linked data sets in the pharmacy because the group that we're talking to supports 70% of pharmacies in Australia. They used hashed Medicare numbers and can track a patient across different pharmacies. So yes, we do have linked data in the pharmacy, and then with our collaborators in general practice, we can, once again through a hashed Medicare number, link the patient's data from general practice with pharmacy. So we're actually testing the linkage process now, between general practice and the pharmacy data. And sorry, the second question was?
Look, we've got multiple questions, but what I reckon we'll do is we'll save them for the end, see if we've got time for them. Okay. Sorry, everybody.
So the second kind of proposal is really around inhaler use, and this is the crux. If we're using inhalers, we need these fine particles to get into the airways, and we have, you know, a few, and this is dependent on quite a lot of things. The left-hand side shows all the technical features of the inhaler, and really we can't do anything about that in practice. It is what it is. It is very complicated, and that's why every inhaler needs to be used in a slightly different way. And then we have the patient-related factors. Peak in respiratory flow, which is obviously disease-related, adherence, whether they're taking it or not, patient preference, which is supposed to make a difference. So I don't really believe any of the patient preference data, because the patient preference data always comes out in preference for the new inhaler. So I would just say, if you read any of that, don't believe any of it. I don't think it's real. And then obviously with cognition, but inhaler technique independently has been shown to be a really important factor. So if you don't do anything but improve a patient's inhaler technique, we've shown that their disease control can improve despite all these other things. Now, why is this, what's the problem with inhaler technique? There are quite a few steps that a patient needs to perform to deliver the dose optimally. It's different for every single inhaler, and we know that patients have problems using their inhalers. This is just an example of some of the errors that patients can make across the different inhalers. And as you can see, some of them are sort of how do you prepare it, how do you position the inhaler, and the breathing maneuvers. And there's a high proportion of patients that make multiple errors. In a recent study that we did, which included 4,000 patients, basically for every single inhaler, there was at least 10% of patients that were making 4 errors or more. And if you just look at a dry powder inhaler, why is this important? Well, this is the inhalation flow, and this is what a patient's inhalation flow might be. But the dose is actually emitted in that very first part of the inhalation. So if that patient delays their peak inspiration past this initial stage, they're actually not going to get a full dose. And the other issue is that we have not solved inhaler technique as a problem for literally decades. This was a beautiful review that was done published in 2016 with a very high sample size of many studies looking at inhaler technique over the last 50 years. And this is what they found. If you look at any of these really, you can see that correct inhaler technique, it hasn't improved. So it continues to be a problem. Now, the question is, what are we doing about it? What are the advances in the area? Is there hope that it might get better? For probably 40 of those 50 years, we talked about the healthcare professional training the patient and training them in the right way and showing them how to use it. And it's probably been in the last 5 to 10 years that technology has come into this domain. The technology up until now has always been device specific. So no one's developed any technology that works across different devices. And what's been the focus of this technology? It's been about some sort of an attachment or inbuilt technology into the device. This one is, this is a really cool one. This is my favorite one. It uses audio, and it was developed by some colleagues in Ireland. And what they were able to, through sound waves, show is not only a timestamp, but actually whether the patient completed the maneuvers correctly, so that the output to that, when it's connected to obviously to a computer, is the timing and whether the dose was correct. So green is correct, and obviously this is daily. And this is just some real data from patients with COPD. And as you can see, very few of them actually take it regularly and correctly. This one's a classic E. So they were taking it regularly, but most of the doses were incorrect in terms of their technique. So what are we thinking here? Well, wouldn't it be great if we could develop something that was for all inhalers? Of course, it would have to be specific for all these inhalers, but it was something that could be developed for all inhalers and for the different techniques, which used a mobile device, and basically either through audio or through actually a video, it had some sort of machine learning or something behind it so that the patient could actually get feedback on whether they were using that inhaler correctly. And that way, I mean, it would take out the issue of inhaler technique and the issue that we have with healthcare professionals actually intervening. I mean, there has been studies that have looked at people videoing themselves and then sending the video to a healthcare professional and things like that. But I mean, really, if we want to make this, if we want to advance this, it needs to be, I think it needs to be something on a mobile device, which when a patient's either videoed, they get feedback straight away about whether they've done it correctly, or whether it's through sound or something like that. So that's really, that was really the second one, which obviously that requires really specialised expertise. So I'll just leave it there in terms of the ideas.
That's fantastic. So I guess I'll jump in and ask if there's any experts in the room on applying CNNs or any version of deep learning to audio and video. What do you reckon the likelihood is of being able to develop one that is inhaler agnostic, or looking at technique or listening to technique? I don't know how many people in the room are experts with deep learning and CNNs, for example. I don't see why it wouldn't be possible, but I think it'd probably be a bit of a challenge, but a worthy one, I think. I think it'd be interesting.
I can comment about acoustic.
Can you hear me?
Yeah. And my MPhil student.
This is Zoe.
Acoustic.
Hang on, maybe you have to speak louder, Audrey. I'm not sure.
Okay, yeah. And one of the big things that we're grappling with is to get adequate recordings. So your technique on machine learning is also affected by whether your recordings are accurate enough in the first place. And if it's just a webcam is adequate, then maybe you've got a potential there. But if you actually have to collect information that's much more precise in terms of you have to hear a pin drop or something like that, then there's a whole lot of things. So it's sort of, if you get rubbish information, it's rubbish in, rubbish out, right? So
yeah, that's right. Yeah, if the diversity of the data that comes in is not diverse enough, or I mean, this is the standard thing we have with radiography or other kind of imaging that people do in hospitals. Often the machine learning algorithm is dependent on the specific machines that the images were taken on, and you try and transplant it into another hospital, and it just simply doesn't work. And so you need to make sure that there was enough diversity in the training data that it was actually recognizing what it was meant to be recognizing, and not just some artifact. So that's a pretty standard sort of problem that is hard to overcome. Sorry, Zoe, I think you wanted to ask a question.
Oh, can you hear me? Yeah, actually, I think my expertise is more on text mining and using deep learning method for text mining. But what some of my colleagues actually they did an application on clinical area. So the idea is that actually they have a lot of disease photo and non-disease photo. The application actually is decided for detect childhood disease, and then basically the algorithm is aimed to detect whether the feces from baby is diseased or not. So they train up this model using deep learning method, and then in order to do that, actually they need to have a lot of disease and non-disease pictures. I think that is the first point. And then the second thing is, I believe in this application, it would be much more difficult or much more challenging. I could totally see that it could be a step-by-step process, because the ability to use the inhaler correctly, actually, if you got some pictures and then you're going to portray it from the picture, it is a very fine difference in terms of from the picture point of view. So that might have certain challenge, but I guess the first thing is you need to have some data. That this kind of data actually is the picture types of data that you could distinguish whether this is disease or not.
Mm-hmm. Well, if anyone's willing to give it a go, and Adam and I talked about, this might be good if we could get a PhD student onto it. I'd be very happy for them to take on this concept.
Yeah, look, I think if it was me, I'd go straight for the audio before I went for the video. But obviously, if you could do multimodal, it would be better. And yeah, I think it's a really interesting one that's pretty sort of high risk, but also because it's a brand new thing, and I don't think anyone has really tried this before in any depth. It'd be a great PhD project for sure.
Cynthia, just to sort of make another comment, I don't know whether you know the literature, they are doing some machine learning on just breath sounds alone. Mm-hmm. And so there is some work already done on, like, let's say if you have some sort of respiratory problem, they're taking the breath sounds for that. And then let's say if you took salbutamol and your lungs open, and then it's a wider pathway through into your lungs, the sound sounds different. So they have started to do some machine learning on that, sort of the before and after. I think what you're trying to propose is much more elegant in the future, which is, completely with the whole technique itself.
Mm.
But there is a bit of work already done.
Okay, great. Thank you.
Yeah. And plenty of people who can also help with the first part as well, probably in the room in terms of looking at connecting up those data sets and having a look at them as well. Yeah, for sure. Does anyone else have any questions? I figure if I continue to pause, then someone will come up with one. But if not, let's thank Sinthia. And I guess we can't really clap, but we can do clap emojis. So